going to be talking today about non-IOP lowering treatments for glaucoma. So these are my disclosures. So we all know that intraocular pressure is a very important risk factor for glaucoma. But it's becoming apparent over the last number of years that there are many other factors that can affect the extent to which glaucoma develops or progresses, at least in animal models and likely in humans as well. And this is part of the explanation that we still see blindness from glaucoma despite effective treatments to lower pressure. And blindness rates have decreased, but we still have a residual proportion of glaucoma patients that progress to blindness despite effective treatment to lower their intraocular pressure. And many of us who have treatments, who have patients with glaucoma, have patients that follow this sort of trajectory sometimes, where they get worse almost irrespective of what you do, and sometimes at very low intraocular pressure. So a major question we have is, what do we do when intraocular pressure reduction is insufficient? One very interesting study published 4 years ago now from Pete Williams demonstrated that vitamin B3, so nicotinamide, modulates mitochondrial vulnerability and prevents glaucoma progression in aged mice. And in this study, they used a mouse model of glaucoma, which is a bit like pigment dispersion, and showed that there was a dose-dependent effect. So the higher doses of nicotinamide almost abolished the progression of glaucoma in these animals. And the idea here is that retinal ganglion cells in older mice have lower levels of nicotinamide, and that increases their vulnerability and to intraocular pressure elevation, and boosting nicotinamide either by diet or by gene therapy was shown to be strongly protective. It protected the dendritic trees of the cells and maintained vision. And so Jonathan Croston and Flora Hui asked the question, could improvements in retinal function in glaucoma be achieved with a similar mechanism using vitamin B3 supplementation? So could a short course of oral nicotinamide improve visual function in glaucoma patients without altering the intraocular pressure? And in this study, they designed a clinical trial, a crossover clinical trial, and were able to demonstrate significant improvement in inner retinal functions. That was the photopic negative response of the ERG at 12 weeks post nicotinamide. And this effect was statistically significant. And in the study, we were also able to demonstrate that a greater proportion of patients had more than a decibel in improvement in their visual field mean deviation with nicotinamide versus placebo. So 27% improved versus 16% in the placebo group. And there was also fewer patients who got worse. So only 4% of patients got worse in the treated group compared to 12% in the placebo group. So the findings of this trial, I think, are interesting, and given that vitamin B3 is well tolerated and has a very good safety profile, the hypothesis here is that it has the potential to be combined with existing clinical therapy as a supplement. But to really firm up that recommendation, we need a much larger clinical trial. And I'm pleased to say that we've recently been funded by Glaucoma Australia to perform a clinical study in glaucoma patients using visual fields as the outcome measure over a longer term study to see whether this is an effect which is able to be demonstrated in a longer term study. There are other ways that we can improve retinal ganglion cell function. And again, this is some very nice work from Jonathan Croston and Vicky Christostomou, demonstrating that in aged mice, if they're subjected to a period of exercise, they become more resistant to intraocular pressure-induced injury. And this is, again, using the electrical measures of retinal function, so the ERG function, scotopic threshold responses, and demonstrating that in the exercise mice, their vulnerability was restored to the level of much younger mice. So the reduction in ERG that was observed in the older mice with pressure-induced injury was almost abolished in the group that were exercised A very interesting effect. And we have many other examples of non-pressure related mechanisms that we can potentially target in glaucoma. And so I guess the main question is, how do we know if this actually works in human patients? And a related question is, do drugs that lower intraocular pressure by a similar amount always reduce visual field progression to the same degree? We tend to make that assumption, but is it actually true? Or are there other effects that these pressure-lowering drugs are having that affect their ability to protect the optic nerve? So really, to make sense of some of these effects that we see in animal models, we need more clinical trials. And ideally, these clinical trials need to be with manageable numbers of patients and short to make them affordable. And I think there are ways that we can use visual field endpoints better. And there are a number of studies and publications on this recently, looking at how we can do simple things like recruiting patients with lower degrees of visual field variability, or perhaps progressing patients. We can cluster field tests at the beginning and end of a study, and we can use trend-based analysis and other aspects of clinical trial design. We can apply futility designs where we abort more studies if they're going to show an effect which is not clinically relevant. There are many other things that we can do. This is a very interesting paper from Auguste Meraz and Jeff Liebman and Len Levine, asking the question, what is a clinically meaningful neuroprotective effect? They argue that a 30% decrease in the rate of visual field progression would have a significant effect on health-related quality of life. The US FDA definition of clinically meaningful progression corresponds to a slope of about half a decibel per year being lost. And a 30% decrease in visual field progression with trend analysis would be equivalent to the effect that we would see with about a 2 or 3 millimeter decrease in intraocular pressure. So just to give an idea of the sort of scale of effect or protective effect that we're looking for here. So my interest is in gene therapy for glaucoma, and gene therapy is already here for some inherited retinal diseases, with many more coming down the line. And I think we're going to see more gene therapies used for the treatment of common eye diseases without a single gene defect in the future, including glaucoma. And we've demonstrated using a gene therapy that involves upregulating BDNF signaling, brain-derived neurotrophic factor signaling. We can show a strong neuroprotective effect in experimental glaucoma. We can greatly reduce the progression of optic nerve damage. And this is a therapy which is in preclinical development with a major pharmaceutical company at present. So we're hoping to get on and start clinical trials in due course for this. So what's next for gene therapy in glaucoma? I think we're moving beyond intraocular pressure being the only way in which we can treat glaucoma. I think there are many other approaches which are promising. I've got a particular interest in using gene therapy to stimulate regeneration and to achieve cell reprogramming. And you're going to be hearing more about the regeneration type approach from Jeff Goldberg following my talk. But just to show you some of the work that we're doing, we've been using gene therapy with a molecule called protrudin to activate CNS regeneration. And this is just an example of how we do this in a dish. This is some work from my lab in Cambridge from Vessi Petrova. And we can laser and cut axons using a laser in a dish. And we can then, and normally they will not regenerate in that situation, but we can vastly improve the regeneration by using gene therapy with protrudin. And you can see here in the dish that it stimulates these central nervous system neurons to regenerate. And we've shown in the optic nerve as well that we can get long-range regeneration by using protrudin gene therapy following optic nerve crush in animal models. So I think this is, but you'll hear more on the regeneration approaches from Jeff. So just in summary, I think glaucoma pathogenesis is complex and multifactorial, and treatment to lower intraocular pressure fails to prevent progression in some. We've got many potential therapeutic strategies, modulators of mitochondrial function and gene therapy. We need smarter approaches to clinical trials to make them shorter and cheaper. And I think optic nerve regeneration and cell replacement strategies may offer hope for the future. So I'll leave it there, and thanks very much. And just a big thank you to those who did the original work that I showed you today.